Okay. Well, thank you everybody for coming today. It's kind of an unconventional type continuing education because normally we're getting critical care type stuff, how to take care of patients. But today we wanted to focus a little bit more on how we can take care of ourselves. We have a lot of other people here that aren't part of our AirMed family, and we want to welcome them today. Just remember, everyone, that this is being recorded, so keep your comments appropriate. And if we have any questions, we'll just save those for the end. I probably won't be able to monitor the chat, so if you have a burning question, feel free to type it, and we can chat afterwards. Okay, I'm going to go ahead and mute everybody if they're not already muted. Okay, and I'm going to stop my video so you don't have to stare at me. All right, before I go, can people hear me okay? Can they see the screen? Might have to unmute yourself, but just a couple people want to let me know yay or nay, so I'm not talking.
Yeah, we see it, Josh.
Looks good.
Good? Okay, awesome. Well, again, thanks for coming today. The topic of my presentation is talking about patient death, the elephant in the room. So our objectives for this presentation, we're going to talk about recognizing the death and dying process. And as you'll see, a lot of what we're talking about is not new because we've all been exposed to this. But I really wanted to just kind of get down and dirty with the research and just making sure we're kind of all on the same page as far as what we're defining as death and dying process. We're going to describe the impact of death and the impact it has on pre-hospital providers. And for everyone that's not part of AirMed, initially this presentation was created for AirMed teams, but I think a lot of it is very transferable and relatable. So when we say pre-hospital, I want to be all-inclusive to everybody and know that this has impact on you as well. We're going to talk about recognizing some of the symptoms of PTSD and burnout and some of the other negative coping mechanisms and positive coping mechanisms that we deal with when we're exposed to patient death. We're going to describe what patient death means to us as pre-hospital providers or critical care providers, and then describe some ways that we can mitigate that stress and handle patient death. Well, what is death? You may think, well, Josh, that's a dumb question. We all know what death is, but I want to give kind of the official definitions of that. So death has been described as the irreversible end of both respiratory and circulatory function, including the brain and brainstem activity. It's also been described as the total loss of the ability of the brain to initiate spontaneous breathing and have a capacity for self-awareness, resulting in the loss of one's soul. So pretty much along the same lines, that's how we view death in most places around the world and in Western medicine. But, we take care of patients from all over the world, and we have to be cognizant of how death impacts them. In my research, it was unique that there's a South Pacific culture that believes life, as generally construed, life departs the body of a person in many different situations, such as when somebody is extremely ill or if somebody falls asleep. So conceptualized, people can be said to quote unquote die several times before their final death actually occurs. So this means that a person can be defined as dead without meeting many of the criteria listed in the above definition, or any of the definitions of what we socially and medically would consider death and what the literature states. So just being aware that death for us can mean something a lot different than death in people of other cultures. So kind of looking at a global perspective, death is a universal event. It's something that we experience either as a participant in or a bystander. And by its very nature, it's genuinely quite individualized and subjective, meaning that our own experiences are going to be just that, our own. Typically, no two people will have the same experience. Death, as we know, is an inevitability that we all share as human beings. And my dad always used to say jokingly, there's two certainties in life, and that's death and taxes. So two things that, regardless of how we're going to experience them, we're going to experience them at some point. A few years back, the United Nations did a study looking at populations throughout the world, and they were able to find that for every 1,000 people, 8 deaths occur. So that leads to almost 56 million people per year, and that's just reported deaths. So there could be a lot more that we're unaware of. Death and grief have been studied among several populations, and obviously there's many commonalities in the evidence between those different populations. Studies have shown, that death of a child can create, not only physical but psychological hardships for the parents and families involved, and that can often lead to avoidance and additional risk-taking behaviors and tasks to evade really associating with the grief. So trying to find maybe other things to fill that void or keep themselves occupied. And that really hit home with me because I know when I've dealt with things in the past, I tend to take on more tasks to not think about it. Maternal death, too, has been shown to really decrease the quality of life among the spouses and children that are left remaining. And that can lead to other mental health issues like a lack of concentration, and even as far as a lack of nutrition for the infant themselves who was breastfeeding. There was a study conducted among Chinese adults that showed that, they dealt with a death a little bit different. They saw it as a way to grieve, and it was a process of healing and really giving meaning to somebody's life in order to really foster hope for their own future and the futures of their family as well. So the CDC aligns quite a bit with the United Nations as far as death tolls. So again, throughout the world, we have about 56 million deaths worldwide. 2.8 of those occur in the United States. And bringing it down even more, about 14,000 deaths per year in Utah. So when we break that down even more, that's about 38 deaths a day and close to 2 people an hour. So it's something that's happening pretty significantly. And as we all know, the leading cause of death, trauma, medical issues, especially heart failure, both in adults and pediatrics, cancer, accidents. So all those things that contribute to that and bring those death tolls up to what they are. When we look a little bit further into the hospital setting, deaths tend to affect us a little bit different, whether we're in the role of physician or nurse, paramedic, tech, but a lot of similarities were found. Although the cumulative effect of being exposed to several deaths over a short period of time had emotional influences, a lot of physicians that were studied found comfort in the ability to attend the funerals of those patients, and it afforded them an opportunity to really reflect on their own mortality as well. What was interesting, though, when you remove yourself from the critical care setting, hospice physicians really attempted to make more of a meaning of their patient's death by keeping the perspective that, yes, death is an inevitability and it's something that is a process, and knowing that the work that they did is quite rewarding to them because they were actually able to accomplish more to give that patient a dignified death. And a lot of times that rewarding feeling outweighed those emotional burdens that constantly exposed them, or that was constantly an exposure from all those deaths that they saw. As we know, the death of children is by far less often, yet it frequently creates difficulty in accepting death, knowing that the child is never going to grow up to adulthood to achieve their goals and their dreams. And this is often brings about emotions of disappointment, sadness, and injustice. And I'm sure we each have our own stories of taking care of a child and mourning their death, not only the death itself, but what life could have been for that child. And, and looking at our colleagues in critical care settings, especially among physicians, they instead accept death as part of the job. They have expectations and responsibility of providing care and really taking action versus being present like those hospice physicians. And, a lot of times these expectations really brought a sense of having to know everything and kind of an increased pressure on that provider, especially when that death occurred. And they often started to question their own competency as a provider, whether it be in a position of nursing or in that physician role. So it can have different effects depending on the setting that we're really dealing with. Well, what is our exposure to death as the pre-hospital provider? Well, we have the basic skills and the equipment necessary and the advanced skills to really treat critical patients when we need to. What we lack, however, are the tools to effectively deal with that patient death, especially dealing with children. As healthcare providers in a pre-hospital role or the emergency department, we often face constant exposure to death, and it leads to an interesting phenomenon called thanatophobia, which means the fear of one's death. A lot of times that's brought about what is called existential slaps, or basically just reality slapping you in the face, or these morality cues or mortality cues, excuse me, where healthcare workers show signs of psychological distress that can be manifested by avoidance from family members or their colleagues, increased irritability, or burnout. In recognition of these cues and their subsequent manifestation are very difficult to identify and to address. Yet the research shows that advocating for education of personnel to assist in mitigating those associated distressing symptoms is beneficial, because healthcare providers, we often lack those coping skills, especially following a traumatic or a stressful situation, which is what we see a lot of time working in critical care and pre-hospital. And dealing with these deaths may have a direct implication on how we can care for patients in the future. Well, why do we care about this? Well, again, as I've mentioned, we've all had that one call or that one patient or several patients that we are never going to forget. They're defining moments in our career. And we also care because it's a shared experience. Even though those experiences are subjective, there's a lot of similarity with that. And most people in the world do not experience death the way that we do. We see it very, very often. I mean, especially look at the Utah statistics, 14,000 deaths a year. How many of those are we involved in, being pre-hospital providers or in the hospital at the bedside? When I was in graduate school working on my dissertation, I was shocked to see that there is literally no literature discussing how patient death impacts us, especially in a transport environment. So that just goes to show that it's obviously a problem. And we just don't seem to quite recognize it like we should, or discuss it like we should, just kind of like an elephant in the room. I love that analogy because it's quite poignant, something that is big and cumbersome and we don't want to talk about, but yet it just remains there. So what are the parts of this elephant in the room? Well, there's awkwardness, a sense of avoidance between coworkers or family members. We're reluctant to talk about our feelings. A lot of times we're in denial because of that, or we're maybe ignorant to our own behavior of how a patient death impacts us. We might try to divert our feelings and change the subject, or get involved in something that's just going to divert those emotions to something maybe more constructive, but that can only work for so long, or we might just often be silent. So many components to that elephant in the room that we deal with. So how are we impacted, and how do we cope with this? Well, we're on the front lines of healthcare. We deal with death more often than most people do in a lifetime. Healthcare workers lately especially have seen it with COVID-19. I have a colleague that did travel nursing back in New York City. She called me in tears one day saying, we had a 15-to-1 patient ratio, and at least 5 people coded and died every day on my shift. We accept that death is part of the job because that's what we sign up for, but we also have to realize that, it's something that we deal with, but we are not good about talking about it or helping each other with it, at least not as good as we can be. And again, there was a surprising lack of literature that found, support from administration. Exactly. I mean, it showed that, we need admin support to provide the resources and help us through this time, but the research never said quite how to do that. It never provided guidance for that. So it's something that, we know this is a problem and this is what we need to do to fix it, but how to bridge that gap and actually do it is kind of the crossroad we're at. We not only need to help each other, but hopefully help ourselves as well. So one of the main problems that we deal with, especially in a pre-hospital setting or at the bedside in emergency department, critical care, can be post-traumatic stress disorder. At least 60% of American men and 51% of American women at some point in their life are going to have a life experience or a traumatic life experience that leads in death or some kind of trauma related to that. So while not all persons who experience trauma go on to develop an actual PTSD diagnosis, almost 15% of Americans at some point in their life will suffer from symptoms of PTSD. And so this is just talking about the layperson that maybe doesn't even have any kind of medical experience or is constantly exposed to that. So taking those numbers even higher. Um, PTSD symptoms are generally grouped into about 4 different types. There's intrusive memories, so having memories of that traumatic event just pop into your mind at inappropriate times or maybe even in your sleep. Avoidance, so maybe avoiding areas where the trauma happened or anything that can bring about memories of that trauma. Negative changes in thinking and mood, and overall changes in physical and emotional reactions. The literature says that there's an estimated 30% of first responders who develop behavioral conditions, including symptoms of PTSD and depression. So almost a third of us. What was interesting was that age was found to actually have an inverse relationship with those stress symptoms, which really indicates that the younger the EMS personnel are, the more susceptible they are to this stress. And the study concluded, that EMS personnel in this setting were found to have quite moderate levels of symptoms of PTSD. Significant predictors of that PTSD in the EMS population were age itself, as we mentioned, coping styles, and the person's level of anxiety and depression, even before the event happened and then afterwards. So these predicting factors can actually be a potential avenue for intervention in order to help improve health of us as frontline workers. Having one's personal life affected by a disaster was associated with higher levels of mental health issues in first responders and post-disaster life itself. And those were associated with stress, depression, and PTSD. So we have to remember that even though this, the stressful event affects us in the moment, it lingers on throughout the rest of our life. And it's something that we have to be cognizant of. Other things that it can lean to or turn to is burnout. That was a term coined in the 1970s from a psychologist that he used to describe the consequences of severe stress and high ideals in quote unquote the helping professions. So burnout can appear in subtle changes, either in personality, perspective and outlook, personal values, and behavior itself. And I think to some extent, we all have suffered a level of burnout in our careers. We can be exhausted. We alienate from work-related activities or withdraw from those work activities. We become cynical. I think that really hit the nail on the head for me. And that's why I didn't work in the ER for much longer, because I really did become cynical. And I didn't realize it till I stepped away from it. And we can have an overall reduction in our performance, both at home and at work as well. So over time, the imbalance of these workplace demands and the resources to be able to deal with that really don't match. We have more of that imbalance than the resources that are available. And frequently burnout is characterized as running on empty, as the graphic shows here, and I'm sure we've all been to that, to some extent. A lot of things that typically have to be in place for burnout to actually happen are a goal-oriented mindset. People come in and they want to have an end goal and meet those goals. Excessive workloads make us more apt to burnout. A negative work environment or even occupational factors. So a lot can be in place that already puts us behind the curve when we have these stressful situations. And people experiencing burnout tend to be focused on the achievement and taking pride in their work and frequently having some level of perfectionism. And again, most of us in this profession are slightly type A, so I think that really speaks to a lot of us. It can get worse over time with the more stress that we're exposed to, or that constant stress that we're not able to get away. They've shown in the literature that burnout is associated with higher turnover rates and absenteeism. And burnout among EMS providers was much more prevalent than other healthcare providers throughout the United States. Other things that it can lead to, anxiety and depression. Sad statistic, approximately 40,000 people in the US and 800,000 worldwide commit suicide every year. Traumatic and stressful events placed on firefighters make them at an increased risk to develop symptoms such as depression, PTSD, and anxiety. Suicide, if you did not know, is the 10th leading cause of death in the United States. And a study in Arizona found that almost 6% of deaths in the state were EMS workers, and a higher likelihood of committing death or committing suicide than that of the general public, with the majority of those patients being less than 55 years old. So that kind of corroborates that people that are younger have more stress and are more prone um, to commit suicide. And in fact, firefighters' exposure to suicidal patients increase their own suicidal ideations by up to 30%.
Hey Josh,
Yeah.
it shows on the participant list that Tracy's raising her hand. I want to say it's Benitez, but I can't tell. I don't know if you want to unmute her or.
I was raising my hand just to say I could hear him. So that was why it was raised.
Sorry, it kept buzzing.
Yeah, no worries, no worries. Let's see, let me get where I was at here. So just a few more things to on that suicidality. So a lifetime prevalence rating of about 28% of people were feeling that life was not worth living. 10% of those had serious suicidal ideations, and about 3% actually had some kind of past suicide attempt. A separate study showed that 30% of firefighters and EMS personnel have committed suicide, which is nearly 10 times the rate of the American adults. So it is a significant problem that we still see today, and it's just not addressed in a way that it should be as far as other people. An interesting study showed as well that people in smaller communities, say more rural hospitals or volunteer firefighters and EMS, they had a lot more structural barriers in place, meaning that they didn't have the necessary mental health services there, or the cost, it was cost prohibitive, maybe inadequate transportation, or they had a difficult time getting off work. So things that can kind of contribute to that as well may not be just our own avoidance of trying to deal with it, but where we live can actually impact that as well. What about us? So looking at the state of Utah, almost 600 Utahns die a year from suicide, and almost 5,000 people in the state attempt it each year. Again, the highest rate is among males between the ages of 25 and 64. And the most common causes come from firearms, suffocation and hangings, and poisonings. It's also a very expensive issue, at upwards of $37 million a year in our healthcare system. And looking at those individuals, 90% of them had a diagnosable mental illness or problem, or an associated substance abuse problem with that. And as you guys may know, Utah has the highest, or the 5th highest suicide rate throughout the United States. So it is a significant problem among us. Other unhealthy coping mechanisms that we often turn to are substance and alcohol abuse. It's the most well-established correlate of suicidality in the general population and those protective service workers, and we fall under that, being healthcare providers. We use these substances in an attempt to really numb the pain or the incident, or really avoid those intrusive thoughts or memories. For trauma-exposed populations, heavy alcohol use is also associated with higher levels of suicidal ideation and depression and anxiety, and really increases those risky and impulsive behaviors as well. An interesting study showed that almost 40% of firefighters missed their shifts due to excessive drinking, yet only a quarter of those departments realized that it was even a problem within their department. And, when you're with somebody for 24, 48, 72 hours, you get to know them, and to have that much of a problem and so little people really know is kind of an eye-opening statistic, saying that, we really don't do well at recognizing this, maybe not only in ourselves, but with our colleagues as well. Other coping mechanisms, turn into food and a lack of exercise. That, for me, it has been a struggle. I eat my feelings because they are delicious. But binge eating has been shown to serve as a mental escape mechanism when we experience negative emotions, or have these negative self-perceptions, maybe blaming ourselves for what happened with our patient, or any kind of perceived harm related to that trauma. In fact, the more severe the PTSD symptoms, the more frequent binge episodes, and the more likely that binge episodes have of providing a mental escape, or actually having dissociative features. So we're actually removing ourselves mentally from that and turning to a vice like eating too much food. But not all coping mechanisms are necessarily bad. Humor is a big part of my life, and with my coworkers at work. I'm sure we've all had an experience, being in healthcare, that you go home for a family dinner around friends that, that aren't in healthcare, and you tell some kind of joke or a story, and they look at you like you just robbed some old lady. I can't remember I remember several holiday dinners that my sister, who's a nurse, and my brother's a firefighter, we told stories and about made other people around the table sick and thought that we were crazy just because of the humor that we had. But as we know, a fine line exists between being humorous and disrespectful. We have to take into context, the joke we make, and know our audience and know our limits. But the research actually shows what we call Black humor to be very effective. It allows us to share experiences with our peers, and makes things more jovial, and actually helps us to get back to the bedside sooner and resume the care for others. And this use of Black humor as a means to deal with that incident, regardless of our role, really can help bring about that camaraderie and support one another in that coping. The Irish dramatist George Bernard Shaw once said that life does not cease to be funny when people die, any more than it ceases to be serious when people laugh. So one thing that I try to do is remember humor and keep a kind of a jovial atmosphere, and keep that Black humor around, because it's shown in the literature to be helpful. Other coping mechanisms that maybe are a little less useful than humor are risk-taking behaviors. One study showed that 50% of staff use alcohol in a short term to deal with the stressful situation, and a fraction of those staff members used illicit drugs too. Another study showed that male EMT drivers drove faster, drank more, and often wore their seatbelts less in their personal life than their female counterparts, whereas those female EMTs smoked more cigarettes and engaged in far less vigorous exercise than their male counterparts. What other activities are we doing that we may consider high risk? It's kind of a double-edged sword. We see the aftermath of risk-taking behavior, yet we sometimes continue to do the things in our own life that mimic that. And it's not always because we're intentionally doing that. We just have this constant adrenaline rush, and we like to maybe do things in our life that can distract us from that. In a just culture, which we preach a lot here at AirMed and really have a strong just culture, risk-taking is often unseen by the individual. It takes somebody from the outside looking in saying, what you're doing is reckless. A lot of times they don't take a risk with the intent to harm themselves or others, but it's something that we need to try to recognize both within our colleagues and within ourselves as well. Well, unfortunately, a lot of times ignorance, is bliss. Are we even able to recognize what's happening around us? I think of the analogy of the frog in boiling water. If you throw it in immediately, it's going to jump right out. But if you put a frog in and heat up that water, it'll slowly cook to death. So I think a lot of times we get in situations that we can be ignorant to our own behavior. And ignorance is bliss. And are we willfully ignoring our thoughts, our behaviors, and our actions? And what happens when we actually start to look inward and address these inner struggles? So this kind of leads to how we as pre-hospital and in-hospital providers are impacted by this. We often withdraw, keeping ourselves busy, maybe not communicating as well with our colleagues or our families. Anger tends to be a rising issue, that we take out our anger on our colleagues or our families, our children. And then that increased risk-taking behavior levels, a lot of times unbeknownst to the individual. And unfortunately, that can also lead to substance abuse. And probably one of the biggest killers, I think, of us in transport is that complacency. Again, we don't intentionally do things a lot of the time that would hurt ourselves or others, but when we have that complacent attitude to our own behavior and these disturbances that we have, we need to start being cognizant of that. Other things that it can lead to is trouble with our colleagues. Are we seeing this within our colleagues and saying something? Do we have the relationships and rapport available to be able to sit down and say, hey, I notice you're struggling. What can I do to help you? Have we talked to them about that? Are we providing education to our colleagues? So maybe if we feel we can't talk to them one-on-one, that we're creating an environment that lets us talk to them about patient death. and really work to mitigate some of these issues. If we are doing that, great. But I think the bigger question is this, are we recognizing the trouble with ourselves? Are we able to turn this mirror onto ourselves and say, you know what, I'm having a problem. The patient that just died in front of me, I'm having an emotional response to that, and it's normal. And I can grieve, and I need to talk about it. So I think that's almost the most difficult thing. I am really good at giving advice about stuff like this, but I am horrible at taking it because it's hard to turn that mirror onto yourself. Well, crap. Now what? How do we get unstuck? How do we help each other become unstuck? How do we mitigate these negative coping mechanisms? How do we mitigate a culture that doesn't promote talking about patient death? How do we overcome this? Well, these questions really led me to my doctoral dissertation, and I wanted to study how specifically patient death impacted transport nurses. But again, as I mentioned, there's a lot of transferability with this to our colleagues in the emergency department, in the intensive care units, to our pre-hospital colleagues, police, fire, EMS. So what I did was I conducted a study where I talked to several transport nurses throughout the United States. And one of the main concepts I used was from a German philosopher that compared understanding a human's experience to watching bacteria. There's only so much that you can learn by just looking at them at one point in time. We have to study them. We have to know where they come from. We have to know what they're made of, what surrounds them, what creates the environment in which they thrive, what are the downsides to their environment, what can cause them to not thrive. Only then can we truly know their nature. So this was kind of the driving force and the lens in which I looked at patient death impacting us as healthcare workers. And 5 major themes kind of came up. And, when I was looking through my interviews, a lot of this struck home with me. And I thought, I felt this way before, but to actually hear it from other people, I think sometimes that in a way is validating to us. So I want to share some of the answers that I got when asking questions and the themes that came up. And the first theme is the what if question. Do we doubt the care that we provided? Did we do everything we could have? Is there something else we should have done? Is there something that we missed? Patients often turn the corner, as we know, and get worse in the blink of an eye. And how many times we look back and ask that infamous question, what if? I kind of clump into this too, the shoulda, coulda, wouldas. And some of the responses I got, they quoted and said, I think the first thought in my head was, what did I miss? What did we miss as a partnership? Could we have intervened sooner? I cried. I had a lot of emotions. I think the first was shock, then mixed with anger in there, anger at myself. He was so young, and hearing the family in the background crying and screaming was really tough. It was really tough. Another participant said, it hit me like a punch in the stomach. What did I do wrong? What did I miss? How could I have done better? Another participant, it was a younger man. It was a semi versus semi. He was texting and driving and rear-ended at estimated 45 miles an hour. He was awake and talking to us, but he arrested again as we were descending to the level 1 trauma center where we were at. We continued to work him in the ED. We stayed back in the ER when they finally pronounced him 25 minutes later. He's one of those calls that you wake up in the middle of the night and remember, and that's been close to 8 years ago. And finally, in the acute care setting, we have the opportunity to prepare. It's not something that usually comes to a surprise as the caregiver. And he went on to say, my own father's death did not affect me as much as some deaths did earlier in my career because I watched it progress. I knew my father was on the downhill slope. And over several days, I could see that versus somebody else who was then walking and talking and now they're dead or dying. The third theme was, why this patient? And, we typically ask this quite a bit in retrospect, especially when the patient's young or otherwise healthy and they die on us. And it's usually precipitated by some kind of traumatic event. In the hospital, when I worked in the ICU, yeah, we had time to typically prepare mentally for these deaths, but in a lot of cases we don't. One of the participants said it was a younger man. And, oh, that's the one, the semi-patient. Oops, I had that on there twice. My bad. Let me give you another quote here. Yeah, my own father's death didn't impact me as much as it did earlier. I know in my own experience, I think why this child, I had a 18-month-old that was abused by the babysitter. And I thought, why this child? Why now? And it's the questions, unfortunately, that we're never really going to get answered. The next theme was partnership and provider bonds. The partnership creates bonds and relationships that really facilitate communication and the ability to tell each other that, yes, you did everything that you could have. Some of the participants said, I've never been made to feel like I was overreacting. I was actually able to sit down with my partner and cry it out and talk to them. And I was very fortunate that the kind of partner that I had was so understanding of what I needed. And I was understanding of what he needed. Another participant said, I've always had partners in these traumatic experiences where there's been a lot of empathy and support. I've never been made to feel like I was being silly or overreacting, and I've been very lucky to have that. And I think to an extent, we can all agree that the people that we work with are like family. We may not always get along, but we share experiences that other people never have. And so that kind of creates an unspoken bond between us. And those bonds and those partnerships are really going to be what help us get through these tough times. Again, like I said, I'm very grateful for my coworkers that helped me get through these tough times. And hopefully everyone listening has that to some extent, or at least knowing that, if you don't feel like you can talk to the people you work with, you can. There are people there that want to help you and really do want to listen and help you process these experiences. Because granted, or if you experience something together, you're more than likely going to be sharing the same type of grief, and it can be important to help each other through that. Another theme that we saw was the debriefing process, or should I say the lack thereof. In education, if anybody's been through a high fidelity simulation, the debrief process is probably the most vital process in learning something, especially a new skill. It lets us learn from our mistakes, see the mistakes of others, but yet we know it's a simulation, so we can kind of take it with a grain of salt. But the research has showed, and in all my interviews, that there is no formal debriefing process after a patient dies on a transport, even though it says that it's important and that we need that. So, the stigma still remains about talking about the call, how it can feel forced and almost be like the dog and pony show that somebody comes in and says, hey, we're sitting down as a group and we need to talk about this. Well, that isn't always beneficial. If a debrief is done, my participants said, it needs to be done by someone who's qualified and not just qualified, but really truly understands what we do and what we see. And as we know, we're kind of a beast among ourselves. Our departments are very unique. Our personalities are unique. So identifying that, yes, a Prefrost process is important and vital, but yet we're lacking the understanding of knowing how exactly to do that. Some of the people I talked with in my interview said, if debriefs are not done immediately, that's okay. It's often okay to be able to take some time away from the situation and let patient or people process their thoughts and come back to it. So oftentimes, more than one debrief may be appropriate, and we may get or may not get participation in that. So a lot of opportunity for improvement is on the horizon for us, especially with debriefing processes. The final theme that came up was protective mechanisms. The big thing was mentally distancing ourselves from our patients. So purposely avoiding creating a bond or getting to know them when we're on these calls. And a lot of times our calls or our time with our patient are limited, but there's times that we can forge some pretty strong bonds with these patients. Some people cope by burying themselves in their work, which increases their likelihood of burnout and job dissatisfaction. And many people may think twice about taking chances in their own lives. One of the participants said they went on a gentleman that went on a skydiving accident and his chute didn't open. And she forever will never go skydiving or anything remotely close to that. Positive outcomes with this comes with experience. And so, participants agreed that as people get older and more experienced, they're really able to look at life a lot differently. They could accept death more as inevitability, even when doing everything they could to help the patients out. we can turn to that difficult time and focusing on our patients and really talk to them to, maybe reach out to those family members and let them know that, yeah, your family member was comfortable when they passed away, and we made them laugh. We provided medication and comfort. So, we're all going to deal with a patient death differently. Sometimes it helps to kind of break down those protective mechanisms and spin it a little bit, where we're focusing on the patient and maybe providing that loved one with a thought and a memory that, they died with dignity and they were able to get some comfort during that time of stress and trauma. Other protective mechanisms, and I'm guilty of this, we tend to get angry and push people away and be destructive in our own personal behavior. So again, it's something that we may not be really aware that we're doing, but other people can see in us, or you can see in your coworkers, and it's okay to reach out to them and just say, hey, what can I do for you? I'm here for you. Well, how do we accomplish this? I think creating a culture of inclusion is something that's very important. Letting people know that, the stigma of patient death and talking about emotions is a thing of the past. And however you process death, you are accepted here. We will provide resources in order to have that. We also need to break the stereotype. I had an EMT that I've been friends with for a while that moved out of state, and he called me one day, and it was the first patient that was a child that ever died on him. And he was so scared to talk to anybody because they were worried about him. He was worried about their perception that he would feel weak. And that really kind of struck a chord with me. I thought, wow, in this day and age, is there still such a stigma and a stereotype that we can't show emotion or process a child dying in front of us? And it's something that I think that we really have the opportunity to work on, and can take a step back and say, hey, it's okay to grieve. It's okay to know that, yes, you witnessed something traumatic, and it's okay to talk about it. Well, now what? As I mentioned before, we really need to work on this culture of inclusion that includes being able to discuss patient death. We're very fortunate at AirMed to have a supportive administration who has been putting into place procedures and processes that let us talk to individuals through a resilience center and facilitate debriefs by qualified personnel when they need them. I think taking the next step further and really focusing on maybe smaller debrief sessions when a patient passes away in our department, or if we have a patient death on a transport and we're still continually busy, being able to take some time out and talk about this, pulling ourselves out of service a little bit and dealing with it in our own time, and be able to have the supports in order to do that. We need to not be afraid of speaking up when we notice that there's an issue with our colleagues. A lot of people could be silently asking for help, and they're relying upon that one person to approach them and say, what can I do to help you? And I'm here for you. And then finally, having the courage to really turn that mirror on ourselves and be open and accepting to take the help that is there. I wish with patient death and how it impacts us that I had a magic pill or some kind of quick fix that says, if a patient dies, this is how you handle it. Unfortunately, I don't. It's something that is continually evolving. And I think if we can create a dialogue and an environment of inclusion within our own departments, that we can address that elephant in the room, and ideally it's not going to sit on our face and ultimately kill us. And that's all I have. I appreciate you all coming here today. If anybody has any questions, I welcome them. If not,